Good evening, everyone. It's my pleasure to welcome you for this virtual initiative, Meet Your Expert. Though we have this inaugural meeting as a hybrid, but in future it will be continued as a virtual meeting. The purpose of this event, Meet Your Expert program, is to create a dynamic and supportive environment for you all to expand your expertise, exchange your knowledge, ideas, while you shape up today for secure ophthalmic care tomorrow. Today, I'm very grateful that we have Dr. Dushyantha Wariyapola. Thank you very much, dear sir, for your presence despite your busy schedules. I want to thank Mr. Chanaka Gunatilaka and his team of Alcon Sri Lanka with a short notice for this sponsorship. Dear colleagues, let's join together to make this event a success, and I want you to contribute, actively participate, and make the most of this program. Dr. Dushyantha Wariyapola, for you.
Kusum, for giving me this opportunity, actually. You can hear, no? So it's nice to have called me for the first of these the meetings. And so we thought the first one, since it was on pharmacodynamics, it's basically meant for trainees, but it's nice to see some outsiders joining in as well, some from out of Sri Lanka as well. Great. So thanks, Kusum, again for asking me to do that. And then, of course, Chanaka for agreeing to do this first one as a hybrid meeting so that it's more interactive. And though you said I have a busy schedule, I don't have much of a schedule on Sunday evening, so it wasn't too bad today. So let's start with the thing. So we are going to talk about pharmacodynamics. It's basically meant for trainees. So we invited physically only the people who were supposed to sit the exams over the next few years. So we have now so many batches. Every 6 months, we've got a batch coming in. So so we have about 25 people, I think, altogether, who's going to sit the exam over the next 3-4 years. So the topic today is pharmacodynamics. So we'll just go through the pharmacodynamics part. Now, phaco machine, as you know, has, so this is one of these Alcon phaco machines, the Centurion. It's got a handpiece, a foot pedal, a pump system. So you've got so many stuff in there. So let's go through each one and then we'll discuss how we can alter each parameter to get the best, the maximum out of when you're doing phaco. And please be interactive. If there is any problem, you can always stop and ask me. So we'll go through each one. So the phaco machine has those parts. And then when you look at the phaco machine, it does 3 things actually. There is an irrigation. Then you need to aspirate the fluid that is there. So you need to have a vacuum to aspirate the fluid. And then to phaco, you need ultrasound energy, ultrasound power. So these are the 3 things that we basically have in a phaco machine. The more sophisticated the phaco machine is, more features you will get with each of these parameters. So if you look at the foot pedal, it can be, you can have 3 positions actually. So first position is, position 1 is irrigation. This is when you have a phaco power mode. You have irrigation in position 1. Then you have position 2, aspiration. And then when you go down further, phaco power kicks in and you have phaco power as well. So in just to touch about the dual linear foot pedal. So the traditional foot pedal will have, as I said, irrigation, the aspiration and phaco power. I think dual linear foot pedal, somebody asked you, you should know that it's got irrigation in one. In position 2, you can either put to fluidics or ultrasound. And then the other one you have on a side kick. So it's basically allowing you to, do a normal position here, traditional foot pedal, 0 to 1. 1 is irrigation, it's a all or none. In 2, when you do phaco, irrigation, aspiration kicks in for the maximum capacity. When you are in position 2. In position 3, in ultrasound, it is a linear mode. This is a traditional thing, but actually the phaco machines are sophisticated today that you have the ability to change each one slightly. Now in dual linear, you can have in position 1 irrigation, all or none. In position 2, you can have the ultrasound linear, and on the side kick, you can have the aspiration linear or vice versa. You can change it. So that just gives you an ability to control aspiration and phaco power linearly with your foot pedal. So that's dual linear mode. It's available, I think, only with the Bosch and Lomb, right? Yeah, I think hardly anybody uses that nowadays, I think. So again, the same thing here is foot pedal, phaco. We'll just go through the IA mode also. When you are having IA mode only, not phaco, the position 1 is irrigation, all or none. Position 2 is aspiration, and that's on a linear scale. When you go to foot pedal in phaco mode, this is, as I said, irrigation. Then you have irrigation and aspiration, which is on a all or none basis. And only the ultrasound part is linear. Whereas here, if you put IA mode, it is the aspiration is linear. So when you are, if you have phaco, you do phaco, and then you accidentally go on to irrigation also on the phaco mode, remember that your aspiration, you have a bimanual or whatever aspiration one, and then you use the phaco mode to aspirate. You can still aspirate, but remember that you will not have the linear aspiration mode. So you will have a all or none power on the aspiration vacuum. So that will give you a lot of vacuum and flow rate. So it's not correct for you to use that for IA mode. IA mode, accidentally, sometimes you forget to move to the phaco and use this. So that's bad because the aspiration is not on a linear mode. So remember to put to IA mode when you're doing IA. So that's the bad thing about using that. So again, this is the irrigation mode, position 1. You have the fluid bottle, the irrigation line. There is a pinch valve. When you get into position 1, it opens the pinch valve and allows the fluid to come into the eye. So that's position 1. In position 2, now you have the aspiration kicking in, and that is through some kind of pump. So in position 2, you have fluid will get into a waste fluid pack or whatever, and this is the vacuum line. So you have the irrigation line in blue and the vacuum line in red. So this is virtually the IA mode. Now, when you have the third position, ultrasound coming in, you have the irrigation, the aspiration, and then the phaco power is through this, and that can emulsify the lens. Okay, so irrigation again, as I said, is a all or none outcome. It cannot be changed. So how do you change it? You can set the bottle height, or in another way, you can call it the IOP. So it's the same thing virtually. So the newer machines might call it IOP. So it is the pressure that is going to be inside the eye. Directly depends on the bottle height. Why do you need? Of course, you need fluid to keep the chamber stable. And also remember that the phaco tip is surrounded by the sleeve. And along that sleeve only the fluid comes through, and that cools the phaco tip as well. So it does that function also, preventing heat buildup. So when you, now most of us do with this machine, we do torsional. So the heat buildup is less. But if you are doing traditional phaco, where you have to and fro movement, the heat builds up, and it definitely needs the water around that, in that sleeve, to cool it. If you have too tight a sleeve, the fluid will not come in. So the sleeve must match the wound and the tip. So you have to use the recommended sleeve for that particular tip to that particular wound size. If you use a 2.2 and then you manage to push it through a 2 millimeter incision, it's bad because it pinches the fluid. So it's bad, it will build up heat. Also, when you are doing phaco, now we do see very rarely a wound burn. So that is what will happen if you do phaco without having enough thing. It doesn't cool the phaco tip, the heat builds up, and you will end up with a wound burn. How many people have seen a wound burn? Virtually everybody has seen a wound burn. Yes, so even with torsional, you can have that. So if you just go on, sometimes, you know, you go in torsional, you have power, and you see milk, lens milk coming in, that is the emulsified material, not getting aspirated. Stop immediately, come out of the eye, and make sure that your fluid is flowing through properly, and go in. Otherwise, if you just go in and try to think that you will unblock it with your phaco inside, you will get a phaco burn. So don't do that. Come out and make sure that you have proper flow established before you do phaco. Okay. So also when you are doing phaco, if you, as I said, it's too tight, or you move the phaco tip to a side or up or down. So remember, the whole thing has to go around. But if you're not in the middle of this, if you keep, when you're in a difficult situation, sometimes you're unconsciously pressing up or down or sideways. So that can also build up heat there and burn that area. And if you burn the undersurface, especially, there is no way that you will have closed that wound up again. Sometimes you can get away with a little bit of burn in the superficial, because the undersurface will come and hit the thing and the valve still works. But if you burn the inner lip, you will never be able to close that wound. So remember, you have to make sure that phaco tip, you're not imparting any pressure on any wound edges. You are in the middle without pressing on either any side of the wound. Okay. So there are two types of irrigation. The gravity dependent, as you said, you just have the bottle and you can set it at whatever you want. and the active fluidics, where you have two pressure plates which will compress the bag. So you have to have a bag for that. You can't have bottles. And that will give you the required amount of IOP in the eye. Now, when you set the irrigation, the IOP, remember there is thing called patient eye level, PEL. So you're supposed to keep that, make sure that it's level with the eye level and set it there. Otherwise, you're not really getting that particular pressure in IOP in the patient's eye. So you have passive fluidics here. Bottle, the IOP depends on the bottle height. And here, the active fluidics, there is a plate which will give you the required IOP is maintained under flow or no flow conditions. So when, because there are sensors, it can assess the IOP and it can give you the same IOP whether there is flow or not. But in the other one, if there is no flow, the pressure is high. When there is flow, the pressure will be to some extent low. So gravity dependent, we said that depends on the height of the irrigating bottle and how much is it above the patient eye level. Irrigation flow rate will depend on the height of the bottle. Now, active one, pressure plates compress the collapsible saline bag, so to the preset IOP target. So what are the advantages? There is a reliable IOP. Doesn't depend whether there is flow or not. Now, when you are pretty sure that you have the IOP required, you can operate at low IOP setting. So if you have a patient who's got glaucoma, end-stage glaucoma, you don't want a very high IOP, yet if you are doing dependent on a bottle, you still have to have it high because you don't want surge. But here you can work on a low IOP setting because you know that that pressure will be given to you all the time. And also, when you have the bag, you have a height of this thing. When the bag is full, you will have maybe 10-20 centimeters more of pressure. When the bag is only 100 mils, it will be much less. But whereas if you have a pressure plate active fluidics, whether you have 10 milliliters in the bag or 500, it will give you the same. And also there are sensors which can detect surge. Now, when there is break of occlusion, occlusion will come to that later. Occlusion and break of occlusion gives you surge. When there is surge, the machine can detect that and give a message to the plates to press that a little more to give you a little more fluid input, which cannot be done with a bag. So with a bag, what you would do is put the bag as far as possible up to the ceiling if you want to prevent surge. So here you can lower the IOP and yet prevent surge. So that's irrigation. Then you are going to talk about aspiration and vacuum. So there are two pump types, Venturi and peristaltic. Venturi is vacuum-based. Peristaltic is flow-based. With both, you have flow, eventually resulting in vacuum, which pulls fluid. Venturi, you create a vacuum, which creates the flow. So Venturi effect, you know, when you have a gas compressed air going through a tube, it draws fluid from an opening over there. Now, the amount of vacuum that is created is directly related to the speed of this airflow. So you're going to control the vacuum that is going to be set, and that is directly related to the flow. Flow depends on that. You cannot separate vacuum aspiration from vacuum. But it's, and you need compressed air furnace. You either have to have a nitrogen cylinder or a compressed air generator. I think your machines, I think, have a compressed air generator, right? The vitrectomy guys, VR guys use a Venturi pump because you need to start fast and stop when you want to stop. Now that is pretty fast with a vacuum based one Venturi. You can stop the airflow immediately and then the vacuum stops immediately. That's the advantage with a Venturi. Now the peristaltic pump works by a roller, a fluid, which rollers are there, which will roll up and then squeeze the tubing, creating a vacuum here, which will pull fluid from the eye, from the end of the tube. Vacuum will, you will create a vacuum, but vacuum will not build unless somebody stops that flow or occlusion. Now, it is said that you can separate the vacuum from flow in peristaltic pump. So that is one of the major advantages with a peristaltic pump. And it is slower than a Venturi pump. So it is good for failure. But having said that, the modern peristaltic systems do rotate so fast that it can virtually mimic a Venturi pump. But you can set it the way you want. So what you control in position 3 would be how fast the rollers are rolling. That will create the vacuum to pull fluid from the eye. So this is a picture which tells you what happens. So here is an irrigation bottle. It says 24 inches high. And if there is no tip occlusion, it rollers at 50 revolutions per minute. Now you remember when you press on the foot pedal, that's what you change. How many revolutions per minute? It pulls fluid from the eye. And there is no occlusion. Its IOP, they say, is about 6 there. Now, if there is partial occlusion here, partial tip occlusion, then the vacuum line never reaches a preset maximum. So what you can set here in a peristaltic machine is the maximum vacuum that you can set, you can achieve. That's all you can set. So you can't really control vacuum and flow separately. You can only control flow. You put a limit to the vacuum that you can achieve. So it is not, but though they say you can control separately, you cannot. You can only control with your foot pedal how fast the rollers are rolling. That's all. But if there is no occlusion, the fluid will just come in and it will never reach the preset maximum. Now, if you have a partial tip occlusion, IOP say rises to 22, it still hasn't really reached the preset max. But remember, now imagine if there is complete tip occlusion, there is no flow, it will reach this preset maximum. You can set whatever you want the preset maximum. And then what happens is it reaches the preset maximum, and at that point the rollers will stop. So that is how you indirectly control vacuum and flow. So it can detach to some extent, but only the fact that your preset maximum can be set. That's all. So we are talking about rise time. So with a Venturi machine, the rise time is very fast. You can open the valve and it will just go through. But with the newer modern phaco machines, you can control the rise time. That is the time taken by the machine to reach the preset maximum once the tip is occluded. So Venturi pumps are very high. Peristaltic pumps, you can set the way you want. Rise time, you can, you see the machines, you can set it at 1 second or 2, 3 or whatever. So it depends on how you want it to rise. So if you are a beginner, maybe it's better to use a low rise time. If you are advanced, you are pretty sure what you are doing, you can put a lower rise time. So if you want to do phaco fast, but you can have an average one as well. Okay. This is just to talk about venting. If you aspirate a piece that you don't want to aspirate, say you have by mistake caught the iris, you have the ability to vent. You have a side kick to the left of your foot pedal, which will create open the vent valve and push in a gas air bubble, which will push this piece away. So that's a vent, that's venting. Now, aspiration flow rate and vacuum. So we talked about aspiration flow rate, depends on how fast the rollers are moving. That depends on where your foot pedal is and what you have set. The followability of pieces that are inside the eye depends on the flow rate. How fast pieces come to your port depends on the flow rate. I think there is so if you have a low flow rate, things will come slow to your port. If you have a high flow, things will come fast. So depends on how fast you want pieces to come to your port. Now remember, you have the phaco tip and then the irrigation line is behind that, and then you have 2 holes on the irrigation line which create the flow. So make sure that these 2 irrigation ports are kind of horizontal. And the phaco tip to the desired angle you want, keep the 2 holes horizontal. So if you are doing bevel up, you can have the 2 ports on the side. But if you are doing most of the time, say, bevel to a side, you keep it still, turn the sleeve in such a way that these are horizontal so that it creates an eddy current, which will, now the eye is like that. So it will, flow will go through that and then come inside to the port. So you use that. Sometimes really you see pieces that are under the incision. So there is no eddy current there that gets stuck there. So just be aware that you might miss a piece there. So eddy currents from the infusion orifice to the phaco tip. So this is the zone of followability. Pressure gradient. Okay, so high flow, high followability, low flow, low followability. So if you are, and then vacuum means holdability. How strong your hold is on a piece that you have caught. So high flow rate, how hard you can catch a piece. So that's what the vacuum means, that. Higher the vacuum, greater the holdability or the grip on whatever you are holding. So as I said, the peristaltic systems, we say that you can separate flow from vacuum. Why do you need to do that? When you want a reasonably high vacuum, you want to hold whatever you are holding, but you don't want stuff to come to your port too fast. So let's say you have a small pupil. You are want to catch a piece, you want to come to the center and then phaco it. You don't want the iris, which is pretty close, coming to your port. So you don't want that. If you have a PCR, you don't want, you just want to hold a piece with low followability, hold it. You want to bring it to the center and then phaco. So you, in this kind of or sublux lens, where there is some vitreous somewhere, you want to have a low flow, reasonable vacuum setting. So some people call this slow motion phaco. So that's why sometimes you need to separate vacuum from flow, and most of the time what you really do is use a low flow, high reasonable vacuum setup where you hold it properly, but you want things to come slowly to your port. Then the third parameter is phaco power. So phaco power, we know that the phaco tips, phaco handpiece has piezoelectric crystals. These crystals, when you give electricity, it vibrates. So that's the basis of piezoelectric crystal. So it can convert electrical energy to mechanical energy, and power, you have a oscillation, which traditionally is longitudinal to and fro movement. So this is what is called the stroke length. So how far the tip moves. So when you say phaco power, we talk about 5%, 10%, 30%, 80%, 100%. So that is out of the maximum possible, how much you are using. So it depends on the phaco power that you are using. So if you have 100%, you use the whole stroke power. 50% is half of that. Then also the movement of the phaco tip, the oscillations, how frequent. This is in the ultrasonic range. It can range from 25,000 to 60,000. So some people think that lower the range, lower the heat buildup. Raghu, what's your this thing? 42,000. Your oscillation rate in the Alcon machine? 40,000. So they use somewhere. I think the Bosch and Lomb has the lowest, no? 25 or something. Those days they used to have that. So, but I don't think it really matters. So some people tend to feel that lower gives you lesser chance of wound burns, heat buildup. So then there are two mechanisms of phacoemulsification. We don't really know how it's done. Bubbles, cavitations as the tip moves forwards, the compression of gas atoms, then the tip moves back, expansion of these gas atoms, release heat, shock waves, disassemble the nucleus at the phaco tip. So that's one theory. Then you have the jackhammer effect or acoustic wave. Whatever it is, it works and it emulsifies the lens. So that's the mechanism, how theories of phacoemulsification. Now, there are two phaco modes that's currently used, maybe more. Traditionally, we have the longitudinal, which is to and fro movement. And now we have this torsional power, which is more an oscillation. So you used to have to and fro, which emulsified it. So now you have a rotatory movement. The piezoelectric crystal is designed in some way to, rather than to and fro movement, to give you an oscillation. So again, now here the torsional power would be from maximum, 100% is maximum allowed, 50% would be half that. So why do you want torsional power? Longitudinal power generates more heat. Torsional rotatory movement generates less heat. So definitely causes less wound burns. Torsional can also, if you're careless, you can have, I have had wound burns with torsional. If you are careless, you just ignore the milk, lens milk. They call it lens milk. When you are doing phaco and suddenly you see kind of milk, and then you just go on, that's called lens milk. You can get away a little bit of lens milk in torsional, but not too much. But phaco, longitudinal phaco, you have even a little bit, you have a wound burn definitely. So that's the main, most important advantage is this wound burn problem, heat generation. It's less. This also works against, I mean, you're trying with a vacuum to hold a piece, but if you have longitudinal power, you are pushing that piece away also. So it's two actions, vacuum and this phaco works against each other. Whereas if you have a rotatory movement, that won't repel the piece that is being held. So you have a piece like that, you have the phaco tip here, and it will work on the surface, and this piece will kind of get rotated and then come into the to the phaco tip. Whereas if you have longitudinal, it will just go on. You'll have to have more vacuum to hold it, and yet every time you have longitudinal phaco come in, it kind of pushes it away. So you go in, and so in longitudinal phaco, you go into a piece and phaco it from within. Whereas in torsional, you should not do that. Torsional, you must be on the surface of. You should not go in and bury your tip inside and try to phaco. So you should be on a piece surface and phaco it so that this piece kind of rotates and gets in. So the way you do phaco is slightly different, or definitely different from whether you are using longitudinal or torsion. And so obviously when you use longitudinal power, you have lens chatter more, pieces get repelled away, whereas torsional, it gives you less. But remember that in longitudinal, you can use a straight needle or a bent needle. But with a torsional, you need to use a bent needle, because if you have a straight needle, it will just bore a hole in the piece. So only if you have an angle here, that when this rotates, that there is a movement on the edge of the tip. Otherwise, if you have a straight, it will just bore a hole only. So you must, if you are using torsional, you must have a bent needle. So torsional power, we talked about efficient. Well, efficient, I'm not sure. Better followability. I think it is efficient in a way because it doesn't repel pieces, but longitudinal will break the nucleus in a hard cataract far better than a torsion. This is IP, they call it intelligent phaco. So what happens is, because it's not as efficient as a longitudinal phaco, when you are doing torsional, sometimes partially emulsified material goes in and blocks the tubing. So to prevent that, Alcon has come up with this thing called IP, intelligent phaco, they call it. When the vacuum reaches 90% of the preset maximum, a little bit of longitudinal phaco will kick in and emulsify that material and clear the block. So you can't change it, can you? No. 90% is fixed. Yeah. So other thing that we are talking about, we don't use this very much now, pulse mode and burst mode, because these were used mainly with longitudinal phaco. With torsional phaco, we hardly use pulses and bursts, but I think you should know what it means. Pulse mode is certain pulses a second. So there are rest periods with no power, and when you go down on the foot pedal, the power of your phaco probe increases, the stroke length increases, power increases when you go down on the foot pedal, but the number of pulses per second is the same. So you set that on the menu. And also this, you can see that this one, you have a pulse and a off time, a pulse and a off time. You can change all that. You can change the pulse time also. So you can have a 5 millisecond pulse and a 100 millisecond off time. If you want 100 pulse and 100 millisecond off time, can also be done. So though it's all equal space, you can change these things. But when you are using torsional, we don't use this because it's not efficient enough. So this is pulse mode. Burst mode is you set the power to whatever you want. So if you have a very hard, dense cataract, you put it at maybe 80% of power. And when you go down on the foot pedal, the frequency of bursts will get shorter. And when you go right down, it is going to be a continuous fade. So when we used longitudinal phaco, most of us use burst mode phaco. For a very soft cataract, maybe you can use a soft pulse mode. So people hardly use that. Again, burst can be how many millisecond burst also can be changed. Now we'll come to surge. I think this is what we need to know. So when there is occlusion of a phaco tip, lens matter is emulsified and flow will go through. But usually if there is no occlusion, flow will be there continuously. If there is occlusion of the phaco tip, the vacuum will build up. At one point, the lens matter will get emulsified, and this is called the break of occlusion, and there is a sudden increase in the outflow. Now, so when there is a sudden increase in the outflow, there will be a mismatch between the irrigation, which is fixed one, and can lead to an anterior chamber collapse. So this shows that you are having a flow here. It's not occluded. Now here you have the piece occluded here, and suddenly it gives way, and then the AC collapses. And so that's basically, so what happens is, the IOP rises, and then there is break of occlusion, and suddenly the IOP drops down because the irrigation is not able to give you that amount of fluid. Then infusion eventually recovers and then comes back to this stable level. So this area, you have surge and the AC collapses. This happens all the time. So good machines will create less surge. If you're careless, if you don't take the foot pedal off, it will cause more surge. So it all depends. You cannot have totally surge-free environment. You'll always have surge, but you can do things to mitigate it. So how can you reduce it? One is active irrigation system. So active irrigation system will detect a break of occlusion and send a message to the two plates and press so that you will get more infusion. Also, it can tell the pump, okay, there is a break of occlusion, reduce the pump rate. So it can do two things. The machines have sensors in the machine. So it will detect surge of occlusion with the flow, whatever they detect. Now the newer systems have some sensors in the phaco tip itself. So if you have a sensor at the phaco tip, it can detect the surge even faster and can respond even faster. So it will be less. So gravity dependent irrigation, you can increase the bottle height. Or you can use a low aspiration flow rate. If you use a low flow rate, the amount of fluid that's going to be taken out will be less. Or use a low vacuum so that the amount of vacuum that is created is less. So you reduce those parameters, you will have less surge. And other one is non-compliant tubing. I think here we have a picture. So if you have a tube like this. When there is occlusion, the tubing collapses, and the moment it opens up, this tubing will also expand. The amount of the volume that is going to aspirate from the eye is going to be this much more than otherwise. So ideal would be to have steel tubing where there is no, but you can't possibly have that. So you have to have rollers. So you have less compliant tubing. Then the other one that Alcon has is an aspiration bypass system, where you perhaps, how many have seen this aspiration bypass hole in the phaco tip? How many have seen? There's a hole in the phaco tip. Haven't seen this? Huh? You use Alcon machines, Alcon phaco tip. So just about a centimeter from the tip, there's a hole in the phaco tip. So what it does is, when there is occlusion, fluid is being taken from that. So there is always some fluid that is going through. So it's not totally occluded, though the tip is occluded. Fluid always goes through that cool, that prevents the sudden, the amount of surge that is going to be there. So handpiece, we said, sensors at the phaco tip, which can detect breaks earlier. So we talked about that. Also, this is a picture to show that the tip, the needle, the phaco tip we use has a flare at the end. So it opens out at the end. So that gives a larger area for you to hold and cut. But in the middle, it's small. So that prevents the amount of fluid that can be taken out, the maximum amount of fluid that can be taken out. So that will reduce the surge. So this is to show that if you have a normal big similar bow tip, amount of surge that can happen. And if you have one of these flare or restrictive tips, the surge will definitely be less. So then phaco tip. Now people also talk about what can hold better and what can cut better. The holdability depends on the area of the opening. So if you have a flat surface, the area is less than if you have a 45-degree tip. So that will have a bigger opening. So the holdability per se will be more if you have a 45-degree tip. Now, what is better to cut? That depends on the surface area of the cutting surface, not the hole, but the outer, the rim, like the disc rim, the amount of rim that is there, which is more. Again, the 45, that will cut more. But now it's pretty difficult to hold a piece with a 45-degree tip. So you're not going to occlude that piece. So eventually we use most of the time something in between, say a 30-degree flare tip, which can give you best of both worlds. You have the cutting ability, you have the ability to hold. So you have somewhere in between where its holdability is good, cutting is good. If you have a 0-degree tip, cutting efficacy is less, you can hold because it can just hold a piece, but the cutting efficiency is less. So you eventually go into a mid-level somewhere. So again, this is to say that there's a hole somewhere here in the flare tip, mini flared. That's, I think, we use mostly mini flared. And then as they have this balance tip with this angle. Anybody uses the balance tip? Hardly anybody. I also never liked that, man. Nobody uses. I used that. I never liked it. So they said that it causes less heat, right? But I never liked that. Anyway. So now that's so. Any questions so far? Nothing. Everything understood. Good. Very clear. Nothing more to learn. Right. So I thought I'll just show you some. Now, what I do, the settings that I generally use so that you can see this. So here is the Alcon the Centurion interface. I generally use a very high IOP, bottle height high. That's my personal preference. Some people might use low ones. So it's just a personal preference. IOP is set at 90, which is a bottle height equivalent bottle height of 122 centimeters. So here I have set, this is for chopping, the initial grooving and chopping. I use this setting, a very low aspiration flow rate. Now I don't want pieces to come to my port when I am doing a groove. I just go in, groove it. I just want a very low flow rate. I don't want pieces to come to my port at all. Vacuum, a reasonable vacuum, 220. I mean, you can have it somewhere there. And then I use torsional phaco. Torsional phaco starts at 20 and a maximum of 80. So when I go into position 1, irrigation on, position 2, you can see that these are linear. You can see that flat line, it's not linear, it's fixed. So I get 18 flow rate. 220 vacuum is just a setting. It will never reach it unless I occlude the tip. And then when I go into position 3, I get torsional power at 20% the moment I go into position 3. And if I go right down, I'll get 80% power. So this is for basically a grade 2-3 cataract, not a very dense cataract, 2-3 cataract. This is what I use for grooving and then breaking it into 2, and then even chopping, I use that. I don't want pieces to come to my port too much. I just hold it with an angle 30-degree mini flare and break it. And then I also have this setting here. I have a slightly lower IOP there, but I have a vacuum which is linear. So in position 2, I get a linear vacuum. So I said the dual linear foot pedal can achieve that. But with a Centurion also you can achieve this. When you go into position 2 and 3, you can have a linear vacuum as well. Sorry, aspiration flow rate. Flow rate is there, but vacuum is set linearly. So the maximum it will reach will be dependent on that. So you have some amount of control in position 2 of the vacuum and the flow rate that you are achieving. So I use that if I have a soft piece of lens matter in the periphery and I don't want to use too much flow rate. I just want to hold it, just bring it to the center and break it or aspirate it. So it's like a epinucleus if you have or something like that, you can use that setting. So remember that you can set it linear in position 2 or even position 3. You can set it linear the way you want for aspiration, flow rate and vacuum. So you can get a linear control in position 2 and 3 with the Centurion machine when you are doing fail. Of course, when you are doing torsional, that is, you can set it linear like that anyway. Understood? Clear. So when I have broken the pieces into whatever number of pieces I want, I go into quad removal. And here I have a slightly higher vacuum and a higher flow rate. And then I use a torsional power starting from 50 to 90. Now I want to emulsify now. Earlier, I didn't really want to emulsify. I just wanted to hold pieces and to break it. I didn't want to go into 20%. So I just go in, hold it until I'm able to hold and then break it. Now here, now I want to take it out. So I start with a 50% minimum. The moment you go into position 3, you are 50%. And then you go into maximum of about 80 or 90, whatever. So that will give you enough power to take out the pieces. So that's for a thing. Now in position, let's say you have a grade 4 cataract. Here I have IOP roughly the same. And when I'm doing chopping also, I use a slightly higher vacuum. And then aspiration flow rate is the same. I don't still want too many pieces to coming to your port. You are just going to groove and break it into 2 until then. And you have to hold the pieces when you want to chop. So to hold the pieces, I use a higher vacuum here. Flow rate is the same. I don't want the pieces to flow into my thing. I just want to hold it with a good vacuum. Now, holdability, I said, depends on the vacuum. You hold it and then you chop the pieces. And then the torsional power here is 50 to 100. So the moment you go into position 3, I get 50% torsional. You can go up to 100% depending on where your foot pedal is. So that's that. And then when you go into position quad removal, I use a higher vacuum, much higher flow rate. I want the pieces to come and I want to hold it properly. And then I use torsional 80 to 100 because I don't want to use low torsional powers which can clog the tubing. So that's the main problem with the Centurion. If you have, because of the fact that you have this non-collapsible tubing, which are thin bore, you have a higher, thicker tubing and the bore is small, pieces get stuck there. So use high torsional power if you don't want that happening. And then that goes on to say that when I have a really dense cataract, I use this setting in quad removal. I have 80 to 100 torsional. Also, I have 50% of longitudinal coming in. So here, I'm using both torsional and longitudinal because I don't want pieces to get partially emulsified and block my tubing. I think that's it. And then just to, there's a video, right? Just, can you set it up? You can. Any questions?
One question,
hi,
what is your settings for hi, sir. Yeah.
Sorry?
What are your settings for direct chopping? What are your settings
so-
for the direct chopping?
So this is basically I use for direct chopping. The can I go back to that? Can I go back to my presentation? So I use like
So I
18, I think 18 flow rate, about 200 vacuum. So go down right down to the bottom. Yeah, keep it. Yeah, this one. So here is about 200 vacuum. I'm not really occluding it. I go into the nucleus, so I don't really. I mean, it gets occluded anyway. You don't really need too much of vacuum there. Aspiration flow rate is low. This is what I use.
okay. I mean, when you're doing the direct chopping, do you need to hold the nucleus quite thoroughly? So don't you need much of a more vacuum?
Not really, because I bury it inside. I go,
Yeah.
I bury it inside, so it's virtually holding adequately. I am so the thing is, sometimes it's pretty difficult to gauge from outside before you start how
Yeah.
dense the cataract is. So
Yeah.
you feel it when you're going, and then only when you're going in, only that you know how dense the cataract is.
Yes.
So in position 3, can I show this? Can you see the screen now?
Yes, I can see.
Yeah. So in position 3 here, when the cataract is a little dense, here I am using a 350 vacuum. Flow rate can be very low. You don't want flow. So here I'm using a vacuum of 350 if it's like a 4 plus cataract. Whereas if I have a 2, 3 plus cataract, I'm just using a 220 vacuum.
Okay. And there's this other thing about the things to prevent surge. I think this IP system is also important to prevent the surge.
Yes,
So
yes, sure.
you don't get full vacuum buildup.
Yes,
Yeah.
that's true. So that's thanks, Mahesh.
Yeah.
Because IP system kicks in, and before it reaches 90%, it kicks in so that it doesn't really allow the vacuum to go up to the maximum preset. So it will kind
Yeah.
of unclog the system. Thank you. Anything else? We just go through just to illustrate one case. It's unfortunately I couldn't edit this. We just took it. I think we start with the side, not the side port. I make the main incision first, and then I make the 2 side ports after that. So the main incision was somewhere here, and then the 2 side ports, the left-hand side port is about 80 to 90 degrees away. The other side port is pretty close to the main incision, where it's convenient for me to put my needle in. I use a needle to do rexis most of the time, unless it's a hypermature or a white mature cataract, where I do a phaco cap and then use a forceps. And then I do take out the piece, and then I do a hydro dissection. So push fluid from one end and then press down at the other end to let the fluid out, and then use viscoelastic. And just remember that just before you go in, make sure that you establish flow, make sure that any air bubbles in the system is taken out. Now here I'm just taking out, making sure it rotates. See, this is, though there is a red reflex, it's a reasonably dense cataract. This is a kind of a 3-4. So I can hold it there. I don't really need to hold it too much. I can break it. And here, obviously, depending on how dense the nucleus is, you can alter the I think we have fast forwarded it a little bit here. This is not my usual speed. This is like, I don't do that fast. So the pieces you can be in the center and take out. The flow will take the pieces into your port. It's pretty fast, I think. And then IA, I use bimanual. Mostly bimanual. And when you're doing IA bimanual, just make sure that you have the aspiration always facing up. Don't turn it to a side. If you don't turn it to a side, you hardly ever will get a PCR when you're doing IA. And some viscoelastic, and then you just put the lens in. And then, since we use methyl cellulose, I use a rod here under methyl cellulose, not under irrigation fluid. And make sure that you take out all the methyl cellulose or as much as possible of methyl cellulose that you have. And then, of course, I go under the IOL and take out most of it. If you use a cohesive viscoelastic for this step, it will be great. But and then just hydrate the wound, making sure that the patient still can see the light, and just I touch and see, make sure that it's kind of tight enough and not too tight by asking the patient whether the patient sees the light at the end of it. If you don't see, you make sure that you release some fluid. So that's the end of the presentation. Yes. Any
So,
questions from
yeah,
anybody?
what
Yes.
are your thoughts about hydro implantations?
That's what I said. I knew that you're
Yeah.
going to ask that. No,
Yeah.
haven't done it, so I can't.
Once the lens is inserted, the surgery is over then.
I know. I'm not. I have enough time, so I'll just go with my. I have only maybe a few more years. I can manage the way I have been doing. I don't want to mess up case after doing all this, trying to do a hydro implantation. And then anyway, I use
It's not like that, sir. I haven't got
Mahesh,
any
no,
problems so
sorry.
far. Yeah.
So sorry, the thing is, I use a rod to put the lens in. So
Yeah, you can't do
so
that.
you can't, if I use
No.
a rod, I can't
No.
definitely use,
Yeah.
I do hydro implantation.
Yeah.
Then otherwise you have this other screw systems. You get the nurse to screw while screw you until you hold the fluid. So Mahesh likes to do that, but unfortunately, since I use a tip, I am not able to do that, unfortunately.
And you can do it in both. You can.
Sorry,
No,
Mahesh.
you can do it with like in the hospital we have this ejector system, the ministry. So not the Indian lenses. You can do it in one hand. You can hold the irrigation from one hand, and you can inject the lens with one hand. But if you have these Alcon lenses, then of course the assistant has to do the screwing thing. The thing is, like, the moment the lens is inserted, you need to take it out quickly rather than wait.
You haven't had any problems, Mahesh, with
Not
this?
so far. Not so far. No.
Great.
Yeah. There are some important points that the lens must be at the tip of the cartridge.
Okay.
And not in the middle, at the tip. And the moment, obviously, there shouldn't be any leaky wounds. And the moment the IOL is released, you need to take out it as quickly.
Okay.
Don't leave it there. So then AC will collapse. And you can
take out quickly.
Yeah. I mean the cartridge, not other things. And the other thing is you can guide the lens with your irrigation, the probe, irrigation cannula.
Okay.
While inserting.
I think, I mean, it all depends on how adept you are and how pressed for time you are. And I'm sure if in your hands it works, but I think it's always safe to use some viscoelastic at least in the beginning. I think for these people, I think they should use the methyl cellulose before they try the hydro implantation.
Yeah, of course it is. And one other thing I noticed,
once you come to Mahesh's senior level, then you can try all these screwing methods and things like that. But for them, I think better to stick to.
It is for the beginners, of course, the standard viscoelastic things.
Yeah.
But I mean, for you and for the seniors, you can try it on. And one thing I noticed, that of course I learned from you what are the places to put the main port and side ports, but I realized that one of the side port is too close to the main wound.
Yes.
Yeah. So the way I can remember that you taught me earlier, it was like, isn't it too close to the main wound, sir?
No. So why I do that, Mahesh, is that I use that side port to put my needle through and do the rexis. I want my hand to be in a comfortable position to do the rexis. So I don't want that to be 180 degrees apart. The two wounds, I don't need it to be 280 degrees apart. So I want it to be at a convenient position for me to use my right hand and put that needle in and do a rexis. So that's what determines how, and then sometimes you have a very sunken eye, and then it's very difficult to go over the brow or whatever. And then if you put it very close, it doesn't matter, as long as they are not going to touch each other, it's okay. So basically I put it in a position where my hand would be where it would be the most convenient place for me to use the rexis needle. Other one I put 80 to 90 degrees away because the
you can't
chopper
hold it,
and the phaco tip basically hold the eye in
blow,
place. If they are too close to each other, then you cannot really control the eye move. The patient can move it. So if you have at 80 to 90 degrees away, you can hold the eye. The patient cannot move the eye when you are doing phaco. But the right hand side port I use reasonably close. I do, and then doing bimanual IA, I don't really. It doesn't matter that they are not 180 degrees apart. You don't have to have it 180 degrees apart. So that's why I don't use it too far away.
I also don't use it for 180 degrees, but somewhere around 140 to 160, like.
Oh, I put it actually pretty close actually now. In a very deep set eye, it's really close.
Sir, I'm Sanjeeva. I have a few more questions.
Yes.
Sir, why do you prefer bimanual over the IA handpiece? Because when we were your trainees, you frequently use the IA handpiece. Now, have you changed that practice?
No, I never use the IA handpiece to do lens matter aspiration. No, from long time ago, I always change. From virtually the beginning, I use bimanual to take out the lens matter, and then I use the IA single handpiece to take out the methyl cellulose or whatever viscoelastic that you have put in after that. So you would have seen that I used the single IA when I took the methyl cellulose off because it's faster. I'm more comfortable with the bimanual when I'm taking the lens matter out, because under the incision I think I'm safer doing that with the bimanual.
So when using bimanual, the problem I have is the AC begins to collapse. Is it because the irrigation pressure is not well maintained, or?
No, I think, and if you have a Sanjeev, I of course don't feel that because if you use the same boat.
Yes, I think there'll be a mismatch between the aspiration and the irrigation.
You can. So I use 23 gauge. I don't know whether you are using 21 gauge or 22 gauge. 22 gauge is pretty big. Now the single IA is a little large. I think 21 or 20. What's the gauge? 21 single IA. That's why I use that 21. No, so single IA is 21 gauge. It leads to collapse more in my hands. But because it's faster, I use it to take out the methyl cellulose or the viscoelastic at the end. But when I use take out the lens matter, I use a 23 gauge. Now the 23 gauge, the problem is it's slow. I know it's slow. It gets blocked as well. So that's the problem with a 23 gauge, but you get very good control with that. Now, if you have epinucleus, you'll struggle to take it out through a 23 gauge. So in that case, you have to either go with the phaco probe again or use a single IA, the 21 gauge IA, and take out the epinucleus if you have a lot of that. But that happens very rarely. So I like to use the 23 gauge, which is very, very user friendly and hardly ever causes AC collapse.
Okay. So the other question, sir, is any other measures you follow to prevent the tube block when you are in mature cataract and increase in the torsional power?
Sorry, Sanjeev, I couldn't catch
Yeah.
that.
Centurions, we have a problem with frequent tube block now, sir,
Yes,
with
yes,
the mature cataract. So
yes.
one thing, so you increase the torsional power to prevent the tube block in your presentation. Any other measures
Yes.
you have?
So no. So what I do is I use longitudinal power along with torsional power when I am doing a dense cataract. And then if the tubing now we don't have the infinity. Infinity doesn't get blocked to that extent.
Yeah.
Infinity, if you get a block, it's always in the tip.
Yeah.
Now in the Centurion, when it gets blocked, it is always in the tubing. So what we do is take out the tube from the phaco handpiece and reverse flush it. You can remember, you press the foot pedal and get the nurse to flush the tubing backwards.
Okay.
So when you do that, you can't do that unless you press the foot pedal. You activate the rollers and do a reverse flush with a 10 cc syringe. Then the block gets clears.
Okay. So any when doing soft cataracts, how is your approach like in the phaco setting?
Phaco setting, I mean, I use the same setting that I use for 3 flow. So I generally use a low flow rate, 18, I think I said, about 200 vacuum. And then I aspirate the center a little bit and then make it virtually a chip and flip method. And eventually eat up the edges until you leave a little bit of a kind of a handle, and then flip it and take out the center. I do only hydro dissection, but ideally I think Howard Fine, when he described this, he suggested that you do hydro dissection and a hydro delineation. Take the delineated part out first and then you flip the other part, but I don't do that. You can eat up the sometimes recently I saw somebody just eating up the center. In the center, just phacoing the center like a without doing a hydro delineation, just eat up the center and then flip the thing the rest of it.
Okay. Thank you, sir.
And then Salvin, I think, suggested that you do from one end and you just kind of spin it out of the eye whole thing. It comes pretty fast in Salvin's hands.
Everything is quite fast in Salvin's hands.
Yeah, fast. Yeah.
I think the soft cataracts, the most important thing is the hydro dissection. You dissect it from the capsule and at least to divide it into 2. If you can divide it into 2, then that is, it's basically the job done. Like
so Mahesh, but the thing is that the softer it is, like you have
it is very it's very difficult to
under 30-40% having a cataract, you will never be able to divide that. So 50 to 45 to 50, 60 kind of person, sometimes you can crack it easily, sometimes it's not. So 40 to 50, sometimes you can break it into 2, but sometimes you cannot. So, so what I do is I try to break it, but under 30-40, I don't even try that. It hardly ever, unless you see a nuclear sclerosis. Sometimes you see a 2-3 nuclear sclerosis in a young person, you can break it. But if you have just a posterior subcapsular cataract or a polar cataract in a young person, it hardly ever breaks. So you have to do a chip and flip. I I find it very difficult to chop it into two. So I try, but I always try. If it's like 40 plus, I would try to, as you said, try to break it into two, or even kind of get a cleavage plane. So you have a partial crack, which makes it easier to do phaco. Okay. Any questions from you guys? The basic questions are also allowed. Nobody has any problems with phaco. So shall we wind up? It's great to thanks again, Chanaka, and you guys for sponsoring this to make it a hybrid event. This was originally meant to be just a Zoom meeting. So Zoom meetings are so boring. So I thought at least the first one will have a physical plus a hybrid meeting so that we get others join in as well. So we purposely didn't send the link to the guys who are here to make sure that the guys come. Otherwise, they may not have come for this meeting. We sent it only to the others who are not registered to the thing. And again, Kusum, thanks for inviting me for this, the first talk. Thank you very much. Okay. And thanks everybody for joining from outside. I see some from abroad as well. And thanks Mahesh and Sanjeeva for all their valuable input as well. Thank you very much.
Thank you, sir.